Can I first thank you all for the enormous amount of work you're doing at the moment. I know the NHS is under great pressure. I know that it's a very controversial time for the NHS with politicians and others commenting on everything we do. But it is absolutely remarkable that you've managed over this period not only to take the NHS forward, but really to improve services for patients against a very difficult background. So genuinely thank you very much for all that work that you do. We're now at that time of the reforms in a sense where, although the parliamentary process has not completely ended, we need to start thinking about how we build the new organisations for the future. Many of you, I know, are thinking about your futures and about your careers and about what contribution that you can make to improving health and healthcare of the future. And hopefully now we're going to start to think about how we put those organisations together and be much clearer about the contribution that you can make. I know many of you have the really important point to make about, do you want to work in commissioning support, in clinical commissioning groups or the commissioning board? And over the next few weeks we'll publish and develop a set of profiles and arrangements for these organisations which will help you make those decisions. This week we're publishing a document on the commissioning board, which is only one part of all of those changes, but I think a really important one and one that I'm deeply committed to making a success. One of the things that I think is particularly important about the role of the commissioning board is making things simple and straightforward for the NHS. If I have a criticism of the existing system, what often happens is at the centre we come up with lots and lots of really good ideas. And we send them out to the NHS. In a sense, we export complexity, and we then expect you in the NHS to try and pull it all together to make sense of it for patients and organisations. What I want to do in this environment is, in a sense, to manage the complexity within the organisation. So when we start talking about to the NHS directly, we're very clear about what it means, and it's simple and straightforward and understandable. And the sectors are a really important way of doing that, of taking all of the complexity around the outcomes and making it straightforward and simple for the NHS as a whole. So the four sectors are going to play a critical role in all of this. They're going to be based on the existing SHAs. It's important that wherever in the Strategic Health Authority arrangements that you currently work, you feel that you can think about working in a sector, but you can also think about working in a local office. I think both of those relationships in the NHS of the future will be extremely valuable for people to do. So what we plan to do is completely consistent with what we'd originally said. We're going to have 4 sectors of this new organisation and 50 local officers distributed broadly on the footprint of the existing clusters. There may be some changes there, but they'll be locally driven rather than nationally determined. We think in that way we can manage the transition between the old system and the new system more effectively, and that you as individuals can better understand the environments that you are working in. If I think about the local officers, as I say, there'll be 50 across the country as a whole. Each of them will on average employ about 50 people. They will be split in responsibilities between direct commissioning, a really important part of that local officer's responsibility. If you think about it, the commissioning of primary care services, dental services, optical services for a substantial population has a critical impact on outcomes for patients, but also responsible for commissioning services for veterans and services for people in prison. These are major issues, I think, and very important for local officers to take forward, which make a great impact, I think, on outcomes. Some of the local officers will also be responsible for commissioning specialised services. A relatively small number of them will be doing that, but nevertheless, the opportunity to reconfigure and change and improve the nature of the specialist services that we have across the country is a vital contribution to great outcomes. The local officers will also be responsible for oversight and development of clinical commissioning groups. And one of the maxims of the Commissioning Board is that we are there to support and help clinical commissioning groups to be the best that they can be. We think that because we think clinical commissioning is of critical importance to improve outcomes for patients. So that role in relation to improving the ability of clinical commissioning groups to turn taxpayers' money into great outcomes for patients is a really important role. We think those jobs are really valuable and will make a real difference for patients and communities as we go forward. When we set it out in our original document, we talked about the Commissioning Board being built around improving outcomes for patients. And that is still absolutely in the front of our thoughts. Outcomes for patients is what most, if not all of us, have joined the NHS for. And this is a real opportunity to work in an organisation dedicated for that. In the design of the organisation, we have built it around outcomes. You'll know in the outcome framework that there are 5 key outcomes for our patients: mortality, the quality of life of people with long-term conditions, the services that we provide for people over a short amount of time when they have an illness or a particular condition, patient safety, and the experience that they have. And you'll see in the document how we're creating an organisation built around those very important outcomes. But we're also building an organisation which is a significance in terms of size. 3,500 people will work for the Commissioning Board, a significant reduction in the numbers that currently work on these functions. We believe that by using more modern ways of working, we can get greater efficiencies out of the system and make people's contribution to improving outcomes much clearer. We've designed the staff of the organisation in such a way that about 1/3 of the staff will work in the centre of it, providing support to organisations outside, but 2/3 of the organisation will work out in the service all over the country. And this is a really important issue for us. As we've gone forward, what we've said is that with new ways of working, it is possible for people to work more at home and to work more locally. So this idea that the talent, the kind of people that we want to work this organisation is more important than where you live is an important design principle as we take it forward. Can I finally thank you for the work that you've been doing over the last period? I know as we go forward, implementing the changes in more detail, that people will have to make decisions about their own futures and their families' futures and whether they want to work in the system or outside of it. All of that I perfectly understand. I think my job in these circumstances is to help and support people and give them the kind of opportunities and choices, informed choices about what they need to do. The development of the Commissioning Board document is part of that. The publication of work around the clinical commissioning groups and the commissioning support organisations will help you take a complete picture of all of that. So I'm keen to work with you and your organisations as quickly as we can to get to a place where you can make informed choices about what contribution you want to make in the future, and we can move forward and build the Commissioning Board to be the great organisation that I think it can be.